as we all understand that contour basically means an outline which represents the shape, so it has to do with the shape of the cornea and we're trying to improve that. And how is it different from topo-guided treatments that Rushad was just talking about? Because we've been doing topography-guided treatments for donkeys years. I think it's been around for 20 years, and it's not something new. But Contoura suddenly broke on the scene, and how? As it is, we've been listening to all these presentations, and we have all these forms of treatments available: the wavefront optimized, the wavefront guided, and frankly, between myself, Dr. Dhami, and few of the other surgeons, we've seen this evolve. When we started our refractive practice, we had nothing like wavefront optimized. It all came up in the early 2000s when, from the broad beam lasers, we shifted to these blind spot lasers, and then the aspheric profiles and everything. And then we came on to the Q value adjusted treatments, and then we went to the wavefront guided treatments, and then we came on to these topo guided and other treatments. So actually the last 25 years have been so exciting. So frankly, we used to think that wavefront guided was the thing to do for a few years, and all of us bought aberrometers and we were trying to do wavefront customized treatments. But if you see here, most of the aberrations actually are on the cornea and you're trying to correct them. If you do an aberrometer assisted treatment, you'll end up treating the internal aberrations also on the cornea, which doesn't really make sense because internal aberrations are constantly changing over as you grow. So if you had to treat a cornea like this, which has a cornea which is irregular, if you feed it into a wavefront guided treatment, you'll probably get an ablation profile like this, whereas typically you would actually want to do this, which is a topography guided profile. So it makes sense to actually try and treat it on the cornea and for the corneal aberrations itself. We've all heard about how you can do the value topography and or maybe on the pentacam also you can do it on the oculizer, and then that data can be transmitted. In fact, the new protocol which is going to come up on the Wavelight platform within the next couple of months is the InnoWise, where we will be using an oculizer and a ray tracing aberrometer to actually feed this data into the examiner and plan your treatments based on that. But for now, we are limited to feeding data from the Vario oculizer itself. And so what is Contoura? Basically, it's a topography guided treatment for virgin corneas. We were seeing treatments on keratoconic eyes, but when you have a cornea which is not keratoconic and it's just a normal healthy cornea. And how did this come about was basically because Alcon applied for FDA approval for topo guided treatments, but they were told that before you go for topo guided treatments, please prove to us that these are safe for normal healthy eyes. So that's how it was born, because they had to do an FDA trial to show that it was the topo guided treatments were safe for normal eyes. And that trial showed up that Contoura treatments or the topo-guided treatments were actually giving better results than wavefront optimized for even virgin corneas. That means the regular LASIK patients. And that is how Contoura was born somewhere in 2016, and we started doing it around the same time when it was launched in India. And initial days were difficult because the planning was not straightforward, and we had to rely upon some kind of a nomogram which was given by Alcon. Nobody knew how to actually use Contoura correctly, and I'll just bypass these slides because we kind of understood that how Contoura is better than wavefront guided and the wavefront optimized. So when Contoura was born, the initial strategies given by Alcon was that surgeons should calculate the treatments based on the patient's manifest refraction. This is what Alcon said, and this is how the FDA trials were done. And the FDA trials were very, very strict actually initially. But however, by ignoring the topography part of the refractive, so as you all understand that, and how is it different from topo-guided treatments that Rushad was just talking about? Because we've been doing topography-guided treatments for donkeys, I think it's been around for 20 years, and it's not something new. But Contoura suddenly broke on the scene, and how? As it is, we've been listening to all these presentations, and we have all these forms of treatments available: the wavefront optimized, the wavefront guided, and frankly, between myself, Dr. Dhami, and few of the other surgeons, we've seen this evolve. When we started at refractive practice, we had nothing like wavefront optimized. It all came up in the early 2000s when, from the broad beam lasers, we shifted to these blind spot lasers, and then the aspheric profiles and everything. And then we came on to the Q value adjusted treatments, and then we went to the wavefront guided treatments, and then we came on to these topo guided and other treatments. So actually the last 25 years have been so exciting. So frankly, we used to think that wavefront guided was the thing to do for a few years, and all of us bought aberrometers and we were trying to do wavefront customized treatments. But if you see here, most of the aberrations actually are on the cornea, and you're trying to correct them. If you do an aberrometer assisted treatment, you'll end up treating the internal aberrations also on the cornea, which doesn't really make sense because internal aberrations are constantly changing over as you grow. So if you had to treat a cornea like this, which has a cornea which is irregular, if you feed it into a wavefront guided treatment, you'll probably get an aberration profile like this, whereas typically you would actually want to do this, which is a topographic guided profile. So it makes sense to actually try and treat it on the cornea and for the corneal aberrations itself. We've all heard about how you can do the value topography and or maybe on the pentacam also you can do it on the oculizer, and then that data can be transmitted. In fact, the new protocol which is going to come up on the New platform, which is in the next couple of months, is the InnoWise, where we will be using an oculizer and a ray tracing apparatus to actually feed this data into the examiner and plan your treatments based on that. But for now, we are limited to feeding data from the value oculizer itself. And so what is Contoura? Basically, it's a topographic guided treatment for virgin corneas. We were seeing treatments on keratoconic eye, but when you have a cornea which is not keratoconic and it's just a normal healthy cornea. And how did this come about was basically because Alcon applied for FDA approval for topo-guided treatments, but they were told that before you go for topo-guided treatments, please prove to us that these are safe for normal healthy eyes. So that's how it was born, because they had to do an FDA trial to show that it was the topo-guided treatments were safe for normal eyes. And they in that trial showed up that Contoura treatment of the topo-guided treatments were actually giving better results than refractive for even virgin corneas, that means the regular basic patients. And that is how Contoura was born somewhere in 2016, and we started doing it around the same time when it was launched in India. And initial days were difficult because the planning was not straightforward, and we had to rely on some kind of a nomogram which was given by Alcon. Nobody knew how to actually use Contoura correctly. And I'll just bypass these slides because we kind of understood that how Contoura is better than wavefront guided and wavefront optimized. So when Contoura was born, the initial strategies given by Alcon was that surgeons should calculate the treatments based on the patient's manifest refraction. This is what Alcon said, and this is how the FDA trials were done. And the FDA trials were very, very strict actually initially. But however, by ignoring the topography part of the refractive effect, it was actually not going to work well. So it was decided that lots of other strategies were designed. So the TMR strategy, which was designed by Carol Poulos, we decided that you should only treat from the topography, which means that don't consider what is the manifest at all, and use the topographic magnitude and axis of the astigmatism and treat that. But that started giving crazy results. It was not good. Surgeons started getting poor outcomes, refractive outcomes. So then some of the surgeons, they started shifting to using, instead of TMR, they went to 50% TMR, which means they were using 50% of the difference between the manifest and the measured astigmatism was used, and that is how they were trying to do this. Again, it was variable. The results were not amazing, but coming to which are the good candidates for Contoura, obviously, as on the left side, this is what were the FDA recommendations, virgin corneas, which was approved for basically 8 to -3 cylinder with 8 sphere, and the lockout was at -9. Good maps, of course, as Rashad pointed out, and you should not do it when you don't have good maps, or when you're doing an enhancement of the stromal stars or lenticular changes, so they are not good ones. So, as we've probably seen that you need very good reliable scans, at least 6 good scans to begin with. That's your first thing. And then once you have good scans, then you can go on to the planning. And when you come out to the planning, you import this data into the examiner platform, and that generates your treatment plan for you, where it basically picks up 2 things. One is the measure, which means the topographic thing, and measures the manifest, and then you can pick out the plans. And you can see that some of them, they will carry a question mark, so those are the maps which are not really that good, and you can select out those maps which you don't want to include. And then comes the decision making. You have 2 values. One is the actual manifest refraction, and then you have the measured refraction which the topographer is picking up, and you have to decide whether you are going to use one of them or the other one, and this is the dilemma that I'm trying to address. So option 1 is to treat the manifest with tight constraints of the manifest to measured cylinder and axis. So we're trying to treat manifest but using the axis and the measured cylinder. The option 2 is to treat the measured cylinder and the axis, making adjustments for the spherical equivalents. Option 3 is you can split it, as we just saw with the TMR, or you can use. So for the first 2-3 years that we were doing Contoura treatments, it was a big confusion what to exactly do till we discovered Phorcides, and I think Dr. Nami and myself were around the same time exploring the Phorcides engine. This is basically a software which was designed by Mark Loganoff, and it's available to us free of cost. In the US it costs a lot of money. This was the Alcon nomogram. So Alcon was trying to say that a difference of more than 1.25 between refraction cylinder and measured cylinder. These patients should be considered for wavefront optimized and not for Contoura treatments. Or if there is a difference of more than 5 degrees between the manifest and the measured axis, if the refraction cylinder is more than 2, and up to a difference of 10 degrees if the cylinder is less than 2. So how Phorcides works is basically it picks out the maps from the images which are generated from the barrier topologizer and then tries to make a plan. And as Prashad showed, that it picks up these taluses which are basically secondary elevations on the cornea. And these are the taluses as you can see. So the talus is this thing over here, and these are taluses over here. So these are basically higher order aberrations which are being corrected on the cornea. And then it puts all these the taluses into the Phorcides software and tries to generate a 3D plan from the 2D maps. And so the software basically looks at it looks at the vector analysis. It picks up vectors for each of the topographic features on the corneal surface, one for the anterior cornea, one for the posterior cornea. These are picked up from the pentacam, and then one for any internal lenticular astigmatism, basically from the internal aberrations or the refraction, manifest refraction which you are feeding. And finally, it basically gives you a treatment plan. So this is what it looks like. It may look a little confusing, but essentially it's looking at four things: the topographic measured axis and the manifest cylinder, the pentacam anterior axis, the pentacam posterior corneal measurements for the astigmatism, and then last is your manifest refraction. And then you will get something like this, which you just saw. So this first line is the manifest, and you have a 5.75 sphere, one cylinder at 10. The value has recommended a 1.54 cylinder at 9, so they are pretty close. You can see the axis is almost 10 and 9, they are pretty close. And here you can see that the cylinder was 1 manifest but 1.5 on the cornea. On the pentacam anterior it's 1.2 at 3 degrees, a little bit off there. And on the posterior cornea, so it uses all these 4 parameters and then it gives you a recommended treatment plan, which is right here at the bottom. So it is suggesting that instead of 5.75, I use a 5.61 and I use a 1 cylinder and fire at 8 degrees. So a little off from the 10, but this is what the topographic is. So it looks pretty good because it's coming pretty close to what you would have done anyways with the extra optimized, but you're also in addition correcting the corneal aberration. So it will fire a 4.52 maximum in some of the areas of the talus, and it will fire a 2.2 in the center, which is very important so that you don't go too deep in the center. So I'll just go on to some cases so that this was just to explain you how it works. This is a 22 years old male using glasses for almost 15 years with a stable refraction, and best corrected vision is 7.5. The acceptance is -1 sphere with -6 cylinder, and at 20 degrees improving to 6 parts. Left eye is -1 with 5.25. At 155, improving to 6 parts. Now, the good thing about these topo-guided treatments and Contoura is that they fire on the vertex of the cornea, and they also have cyclotorsion control in addition to all the other things that it does. So for high cylinders, it's very, very good if you're using cyclotorsion control with these treatments. And on the cornea, these were the Ks. So let's see what it looks like. It's a symmetric bow tie. This is the pentacam map. The bad maps were absolutely fine. Here it looks like this, and then on the eye trace we could obviously see that the astigmatism and the internal the refraction was matching up quite well. And this is how you can see mostly it's an astigmatism, and on the other eye as well. Typically maps are alright. The anterior showed that you can put an ICL if you want for the AC text. So what should we do? The dilemma was, should we do, of course, smile. Today everybody would say that we don't want to do a smile for such high cylinders anyway. Should we do a Contoura femto, or should we offer this patient a toric ICL? So that would have been a choice. Yes, ICL would work, but frankly, with the ICL comes the small risk of very high astigmatism that you may have small changes of even 5 to 10 degrees of the ICL position. The patient vision will go haywire. So sometimes for these eyes, if it is possible to treat on the cornea, I prefer to treat on the cornea, because ultimately the problem lies on the cornea itself and we are just negating it with the ICL. So we went with the Contoura femto LASIK. This was the Contoura planning on the Phorcides engine. And as you can see here, the manifest is at 20, the measured is at 12. So there's a difference of almost 8 degrees between topographic axis and the manifest axis over there. The pentacam is at about 13, and the posterior cornea, of course, is about 0.9, also at 102. So it's recommending that I treat a -1.2, and it has decreased the cylinder to a 5.5, and it's telling me to treat at 19. So it kind of looks good, because as it is with the nomogram from -6, you would have probably come down to about 5 using the normal Arlington nomogram that we use with the Wavelength machine. So this looked good, so we accepted this and went ahead. For the other eye also, the planning showed that instead of the 160, Phorcides is telling me to treat at 161, and the astigmatism instead of 5.25 at 4.64. So both of them look good. This is the final result after the Contoura assisted treatment. And you can see that the central cornea looks pretty much now well corrected from that bow tie that we were seeing pre-op, and so is the other eye. Now, Patient did well. The final outcome was about this much. You can see that the astigmatism seems to have got corrected pretty well. Now, we used to do very well with Wavefront optimized also, but frankly, these were not the kind of results we used to get. I don't know if Dr. Dhani would want to comment on this. When we were treating -6 and -5.5, we would typically still have residual astigmatism of maybe a 1 diopter. Patient used to do well, they would get 6-9 or something. But with these treatments, we've been able to achieve much better corrections of high astigmatism than we ever did. Ravi sir, would you like to put in one word so that then I can go to the next case? Any comment here? Because later on we'll forget this.
The Phorcides really analyzed and clarified our treatments, and we got wonderful results.
So Phorcides has been great, but so has Contoura, sir, because Contoura has transformed our treatments for these very high astigmatism and these high cylinders. I love to do smile, my volume is 70% smile, but where Contoura is required, it really performs well. So we quickly come on to the next case because I know we are short of time. This is a patient who is 5.5 with 2.75 at 90 and -6 with -2.5 at 75. So let's see what it looks like. These are the pentacam maps, and this is how it boils down. It's showing 90 degrees. The measured is 93, which is pretty close, but see the corneal astigmatism is only 1.5, whereas the manifest is 2.75. So almost 1.25 is coming from the internal astigmatism from the lens, and pentacam is showing 1.4, and of course here it is. So now what should we do? Should we treat the full 2.75, or should we restrict ourselves to the manifest, which is the manifest or the topography guided, which is giving us 1.5. Now, if we had gone with the alpha nomogram, we just come to that, we would have probably used the Contoura measured. They would have asked us to use 1.5, but the patient is 2.75, so we don't know whether to. So what is Phorcides telling us? It's saying use 2.39 instead of the 2.75. So it's cutting down, but not all the way down to the measured astigmatism. Same way in the fellow eye, your manifest refraction is 2.5, but the topographic astigmatism is only 1.4. So here there is a disparity of almost 1 diopter or more than that. And again, it is recommending that I treat a 1.91. So this is where Phorcides has been playing a great role, because let's just see what we eventually did. These are the taluses and this is how we treated it. But let me preview to this final chart. Our manifest is right here. This is for the right eye. The measured, which means basically the topographic, is 1.59. The 2.75 on the manifest. Phorcides is suggesting I correct 2.39. The alpha nomogram was suggesting we correct only 1.59, and we finally treated 2.5, and this is the outcome that we got, a 0.5 still, and a patient who has 6.9 unaided on this eye. Now, had we gone with the alpha suggested nomogram, we would probably be sitting with 1 diopter of astigmatism. Same way, left eye, we had a manifest of 2.5, measured was just 1.5, Phorcides is suggesting 1.9, alpha was suggesting 1.46, and we treated 2. Which is pretty close to what Phorcides was suggesting, and we again got a fairly good outcome of 0.25 and 0.5. So to summarize this case, manifest, we've all gone through it. Let's come to the last outcome, and then I'll finish with the last case. Since patient has, if we had used the alpha nomogram, we would be sitting with almost 1 diopter of cylinder in both eyes. So that's where Phorcides has played a great role. Now I'll finish off by just showing when Phorcides tells you not to do a Contoura treatment, because those are also cases where you don't want to do a Contoura assisted treatment. And I'm sorry, Namita, but I'll just finish with this last case. I'm running beyond time. So this patient has a -2 with a 2.75 at 40, and the other at 2.5 with a 1.5 at 145, both improving to 6.6. And here, this is the plan which it has. So now here, what I'm trying to highlight is that the axis does not match between the manifest and the topographic guided. So there's a 17 degrees difference. The manifest is 145, whereas the Contoura recommended is 162, which is basically the topographic axis. And this is how the taluses look like. It's important to look at the taluses, otherwise you can go wrong. And this is what, now just see this line over here. So what is happening is you put it into the Phorcides engine, and because there is a disparity in the axis which is beyond the ordinary, it says Phorcides recommends converting to Wavefront optimized in this case. So then again, the good thing about Phorcides is that it will tell you when not to do a Contoura or a topographic guided treatment, and this makes life much easier rather than applying your mind and trying to guess what to do. So we eventually went with a customized FCAT treatment, and patient did well, and we have almost a plain outcome here. I think I should stop here. I have more examples, but they keep going on, and I will stop here and answer any questions. I think I've conveyed the message hopefully. So Contoura has transformed our practice and on Phorcides has more so. And this is a small slide on another strategy which is now available, which is basically the new something like Phorcides engine. There is another engine now available, which is known as the ZZ-ARP. It's available online. You can use this. We have been doing some studies with this. My two fellows are sitting here, and I put all this homework on their head when we treat all our patients, and we do calculation both on Phorcides and the ZZ-ARP, and it has also looked promising. So with this, I'll conclude. I would love to invite all of you to Jerusalem for the ARC breakdown end of October 25th to 27th, and thank you. And I must acknowledge the support of both my fellows who have helped me prepare these slides.
Thank you so much, sir. I think you've taken us through actually the tough parts, because we mostly show cases where the axes are matching, but these were really beautiful and very enlightening cases. I now request Dr. Vikas to give the mental floor to Guarav. If there are any questions, but we'd like to quickly move on also. So, Dr. Vikas, please give the mental. Meanwhile, I request a very eminent professor who keeps Dr. Rajesh Sinha, who is very kindly being here with us to set up this presentation. He is giving us food for thought, interesting cases of refractive surgery. Over to you, sir.
Also, we would like to welcome Dr. Abhinder Kaur, who is a PMC representative. We welcome him.
At the outset, I would like to thank Dr. Thani and Dr. Nimrata for the invitation. I'll be discussing with you a few case scenarios which will give us some food for thought and regarding decision making.